Afternoon. I would like to welcome everyone for today's session, a webinar on preventive and advanced treatment strategies in dentistry, organized by Asia Pacific Association for Dental and Oral Health, APADENTO, United Innovators. Association Research. The first of Kaustubh, PYW in Amravati, India. College and program from the school of completed his PhD. Seven books on topics like basic periodontology, implantology, growth factors, and lasers, and also did various presentations and guest lectures in international and national conferences. Dr. Kaustubh's today's topic for webinar is vertical ring technique for bone augmentation. We would love to hear from you, sir. Over to you, sir. Sir, you are on mute, sir. Kindly unmute yourself.
Thank you again, Janvi ma'am. Thank you for giving me this opportunity. I hope my voice is audible to all of you.
Yes, doctor. Please go ahead.
Yes, ma'am. So a very good afternoon to all of you. I am Dr. Kaustubh S. Thakare, and today we are going to discuss about vertical ring technique for bone augmentation. If you take out the literature and find about the vertical ring technique, you will be getting one more name given to this technique, and that is bone ring technique. So we are going to talk about the vertical ring technique, that is the bone ring technique for bone augmentation. Before starting with today's discussion, first I will like to pay a homage to my late father, Dr. Suresh B. Thakare. And with his blessings, I will be starting with the discussion for today's topic. Whenever there is loss of a tooth, several consequences are occurring. These consequences, they can be classified as soft tissue consequences, hard tissue consequences, that is bone consequences, aesthetic consequences, and psychological consequences. But as our topic today is associated with bone augmentation, I will be focusing more on the bone consequences occurring after the loss of the tooth. We all must have heard about Wolff's law. This law states that whenever there is loss of a tooth, there is no stimulation to the underlying bone. As there is no stimulation to the underlying bone, bone remodeling is not taking place, and because of that, bone loss is occurring. So after the loss of the tooth, within the first year, what we get is 25% of the bone loss. This bone loss is occurring both in horizontal as well as in the vertical direction. If you are waiting for a period of say 3 years, then what you will be getting is 40 to 60% of the loss of the bone volume. So just imagine if a patient is coming to you after 3 years for implant placement, what you will be getting is half of the bone which was normally present. So 50% of the bone approximately is lost within the 3 years of the tooth loss. And whenever such kind of the bone resorption or the bone loss is taking place, what we are getting is ridge defect. This ridge defect, it is occurring both in the horizontal as well as in vertical dimensions. So if according to literature we have to state, then what we will say that within the first year of the tooth loss, 1/4 of the bony width is reduced and around 4 millimeter of the bone height is reduced. So this is leading to formation of ridge defects, which we commonly say. So many of the times we say that this patient has got a ridge defect and that patient requires implant treatment. So just imagine come to your clinic or your OPD and your receptionist has come and that receptionist has told you, sir, a patient is there for implant therapy. He wants to get the implant done. So what you think? The ridge will be something like this. The ridge is very good. You are going to place implant very properly in this patient and you are going to get good results. But when you see that patient, the actual ridge is something like this. The ridge is not adequate. The bony dimensions are not adequate. And now the treatment which you had thought is simple has become complicated. It is going to require multiple things and you are not sure about the treatment outcome. So finally you start laughing on yourself. So we have talked so much about the ridge defects which are occurring after the tooth loss. Let us now see how these ridge defects are classified. A common classification which every one of us must have heard about is Seabird's classification. According to Seabird, the ridge defects, they are classified as Seabird's class 1, class 2 and class 3. In other words, we can also say it as B, A and C. Let us see what is the meaning of B, A and C. So this is the Seabird's classification. In class 1, as I have told you, there is loss of buccolingual dimensions, that is horizontal dimensions of the ridge are reduced, but the apicocoronal dimensions or the vertical height is maintained. You can see in the frontal view, the apicocoronal height is properly maintained, but if you see the occlusal view, you can appreciate that the horizontal dimensions of the ridge are reduced. That's why it is called as B, because there is buccolingual loss of the dimension. In class 2, we get apicocoronal loss of the tissues. If you appreciate the frontal view, in that there is loss of the vertical height, but in occlusal view, the horizontal dimensions are very well maintained. Class 3, which is also called as C, is combination of both class 1 and class 2, where we are having deficient vertical bone as well as deficient horizontal bone. So if you talk about the treatment and the complexity of the treatment, it will be most complex in class 3. It will be slightly less complex in class 2. And furthermore, it will be slightly less complex in class 1. So class 1, where horizontal dimension is deficient, we can go for some techniques. For class 2 also some techniques are given, and for class 3 also some techniques are given. So depending upon what is the treatment we have to do in each of these classes, another classification is laid down into the literature which we need to know. This classification is HVC classification. Now the name itself suggests that H is horizontal, V is vertical and C is combination. The peculiarity of this classification is that the ridge defects or bony defects, they are further subclassified as small, medium and large. And apart from that, even the treatment modality has also been given. So small defects, they are 3 millimeter or less than that. Medium defects are around 4 to 6 millimeter and large defects are 7 or more than 7 millimeter. So if a horizontal defect patient is there and that patient has got either small, medium or large defects, the treatment modalities which are recommended are ridge expansion, inlay or onlay monocortical grafts and guided bone regeneration. In case of vertical defects, we have orthodontic extrusion and guided bone regeneration. And apart from that, for the medium and large defects, we can also go for distraction osteogenesis. In combined defect, that is combination, for small and medium, we have got the combination of the treatments which have been mentioned in horizontal and vertical defects. And large defects, it is specially maintained mentioned that they are difficult to correct. They require large extraoral block grafts like tibia, rib, calvaria, and multiple procedures are needed. So I had mentioned that the most difficult defects to treat are combined defect. The next one are vertical, and then the next one are horizontal. So HVC classification is telling us about the same thing. So when we talk about augmentation, there are two types of augmentation. First is soft tissue augmentation, and another one is hard tissue augmentation. The soft tissue augmentation are those techniques which are done for aesthetic purpose, for increasing the width of attached gingiva, for increasing the width of keratinized gingiva. They include connective tissue graft, soft tissue autografts like free gingival graft, and combination, which we call interpositional onlay-inlay, where for some part we are using connective tissue graft and for some part we are using free gingival graft. All these procedures, they are useful for aesthetic purposes, but for placement of the implant, we are not going to get any gain in the dimensions of the bone. For that purpose, we have ridge augmentation or bone augmentation techniques, which are again further subclassified as horizontal and vertical ridge augmentation. So different horizontal ridge augmentation procedures are ridge splitting and expansion. We all are well aware of this. We have different kinds of microsaw, different kinds of osteotome, which are used for purpose of splitting the ridge and for placement of the implant. Nowadays, densa burrs are available in the market, which are used for osteodensification, which helps for the expansion of the implant site without any kind of crestal bone loss, without any kind of bone loss on buccal and lingual surfaces, and safe placement of the implant. We have a very known technique, that is guided bone regeneration, where bone grafts are placed and membranes are placed in combination so as to have good healing and good dimensions we achieve with guided bone regeneration. Next one is only bone graft or bone block, where we take a bone block from the intraoral or extraoral side if we are using the autogenous bone, and then that is applied onto the ridge side. Here you can appreciate it. A bone block is placed onto the deficient side and then a membrane is placed. When we talk about vertical ridge augmentation, in vertical ridge augmentation, we have bone block graft, that is onlay or inlay, guided bone regeneration, similar to that of what we have talked about in horizontal ridge augmentation, distraction osteogenesis, where we are trying to enhance the vertical dimensions of the bone, and tent pole grafting. In tent pole grafting, first a membrane is applied. That membrane is fixed with the titanium screw. Then below that membrane, some bone block or bone graft is placed, and a tent shape appearance then appears, which will lead to extension and expansion of the bone, and we get further more dimensions of the bone for placement of the implant. Just imagine one day Hrithik Roshan comes to you and Hrithik Roshan is telling you that I want to increase fat in my body. I want to get myself broadened in the horizontal dimension. Is it possible? Definitely it is possible, because this has happened. You can see Hrithik has been also like this, because if we ask him to eat whatever he wants, in horizontally dimensions will get increased. But if Rajpal Yadav is visiting to you and asking you to make him same as that of the Amitabh Bachchan in height, will it be possible? It is very difficult. What I have seen, some of the auto rickshaws, they are roaming here and there. Some number is written on those auto rickshaws that if you want to increase your height, contact on this number. I don't know what is the authenticity. Otherwise, everyone would have been of the same height. So similarly, why I have showed these two pictures to you, because horizontal ridge augmentation is more successful as compared to that of vertical ridge augmentation. Whatever techniques we have seen up till now, they have got one inherent disadvantage. And the disadvantage is that we cannot place implants simultaneously along with the bone augmentation. The basic reason for this is primary stability. We have always read that if there is primary stability to the implant, then only it is easier for that implant to gain secondary stability. If primary stability is not there, then even the secondary stability is very hard to achieve. Here, if you are going for bone augmentation, it is very difficult to achieve the primary stability. That's why simultaneously along with the bone augmentation, we are not placing implants. we are giving at least a period of 6 months for healing after bone augmentation. This is the minimum period which we have to wait. But many of the clinicians, they are waiting for a longer period of time. Around 9 months we are waiting. So this all leads to increased overall treatment. So just imagine 6 months we have waited for augmentation. After that, placement of the implant. 3 more months we are waiting. After that, prosthetic loading is going to take around 1 month. So 10 to 12 months will be required for a patient to get a tooth. What if any technique is there where along with the bone augmentation we can place the implant also? And one such technique is bone ring technique. As I have told you, it is also called as vertical ring technique. So it is a technique where in single stage we can go for bone augmentation and simultaneous placement of the implant. Here what we are doing is placement of a cylindrical bone block which is fixed onto the primitive bone which is already present, and then that bone ring or bone block is fixed with the implant. The main advantage of this technique is that it reduces overall treatment duration required, and also it simplifies the surgical treatment of three-dimensional bony defects. In literature previously, most of these techniques or most of the authors, they have used autogenous bone graft which was harvested from the intraoral or the extraoral sites, mostly from the intraoral sites. But with autogenous bone blocks, there are several inherent disadvantages or problems. The first one is a second surgical site is required. There are several surgical complications which can occur because of unfavorable anatomic structures. And the most important is patient donor cooperation. Apart from the larger donor site, patient will not get ready easily for a second surgical site and for procuring of the autogenous bone blocks. So nowadays, allogenic material is commonly used for bony augmentation in bone ring technique or vertical ring technique. Next, I'm presenting a case which we have done where we have used this vertical ring technique for getting vertical augmentation. The case which we had selected was having combined defect. That means both horizontal and vertical defects were present in this patient. So we had gone for horizontal augmentation as well as vertical augmentation. And apart from that, a simultaneously we have placed implant also. So as it was mentioned in the HVC classification, multiple procedures are required in a combined defect. Similarly, we had to do multiple procedures for treating this defect. So this is the surgical procedure which we carried out. This is preoperative clinical view. For that preoperative clinical view, we had also taken preoperative cone beam computed tomography. When clinical examination was done, it is clearly evident that there was horizontal defect and there was vertical defect. So the first step was to give incision. Whenever incisions are given onto an edentulous site, commonly two types of incisions are placed. First is remote incision and crestal incision. Crestal incision is that incision which is given at the midline of the crest, and remote incision is any incision which is given away from the crest. This incision is usually placed 2 mm away from the midline of the crest, and it is commonly used whenever we are going for any kind of augmentation technique. So here we used remote incision which was given 2 mm away from the midline of the crest. Two vertical releasing incisions were then given so as to have proper displacement of the flap and to visualize the bone. A full thickness mucoperiosteal flap was reflected with blunt dissection. When we use periosteal elevator for reflection of the flap, we call it as blunt dissection. And there is another term which is sharp dissection, where we are using a blade to reflect a partial thickness flap, that is mucosal flap. So here, as we were working on the bone, we wanted a full thickness flap reflection. When the flap was reflected, it can clearly be appreciated that there was deficient horizontal dimensions as well as the vertical dimensions. So the next step after this was preparation of a bony ring. So this is a prepared bone ring. This was prepared from allogenic bone block. This allogenic bone block we had obtained from Tata Memorial Hospital at Mumbai. After that, a trephine was used to prepare the cylindrical ring. There is a specialized trephine burr available to prepare a ring from that bone block. This ring was then placed onto the primitive bone, and then it was fixed with the implant. So what we did, we first checked the dimensions of the ring, whether it is fitting properly onto the defect or not. After that, similar to the drilling which we are doing for normal implant placement, that was done in the primitive bone which was present already, and also in the ring, and then the implants were placed. Next step was to go for horizontal reach augmentation. As it was a combined defect, we required both horizontal as well as vertical augmentation. So first thing was placement of particulate bone graft. When we are placing particulate bone graft, we have to decide whether we are going for autogenous, xenogenic, allogenic, or alloplastic. So the important thing for bone augmentation procedure is resorption time. If you are placing particulate bone graft material which are allogenic in nature, the resorption will be very fast. That we don't want. We want a bone graft which has got longer resorption time. So we used xenograft, and in combination alloplast was also used. A commercially available xenograft is BioOS, along with commercially available beta tricalcium phosphate was placed, and then a membrane was placed which was collagen membrane. Sutures were given which are resorbable in nature, and this was the immediately taken radiograph post-operatively. So here you can see the bone is present both on mesial and distal surfaces, and implant is in the proper position in relation to the cemento in teeth. So this was the pre-operative picture, and this was the post-operative picture. So post-operatively, you can say that the prosthesis is not looking good. So basically, this prosthesis was prepared for the purpose of trial. But when we were taking trial of that patient was very happy with the prosthesis, and he told that whatever this is, please deliver it to me because I am very happy with the result. But we have planned to go for a proper prosthesis in this patient afterwards. So if I talk about the treatment outcome in this particular patient, then if you are considering a treatment outcome of a patient who has undergone implant therapy, the best way is to identify what is the stability of the implant. If stability of the implant is good, that means your procedure is successful. So for that purpose, as we all know, there is a device called as Austral device, which works on the principle of resonance frequency analysis. So that we used, it is a magnetic device which has to be attached to the implant, and then we get some values. Those values are called as ISQ, that is implant stability quotient. And in this case, the implant stability quotient was 68 after 6 months. So 4 months we waited. After that, loading was done. And after loading, also after 2 months, the ISQ value was 68, which is considered as a very good value. Immediately after the surgery or within 1 month, there was no graft exposure or membrane exposure. Crystal bone loss is a constant phenomenon which is associated with the implant, specifically after first year of the implant, during the first year of the implant placement. So 1 millimeter bone loss, if it is occurring crystally, it is considered as normal, but here we got less than that. Usually what we say that allogenic bone has got faster resorption rate, but here despite of that we got just 0.5 millimeter of the bone loss mesially, and a similar amount of the bone loss was also identified distally. So if I have to give some clinical recommendations and conclusion regarding this technique, I will say that bone ring approach is a good approach for vertical bone augmentation because it is a single procedure in which we are going for bone augmentation as well as for insertion of the implant. A major advantage of this procedure is that it leads to significant reduction in treatment time, and it also simplifies the overall bone augmentation in 3 dimensions. Some of the things which we have to keep in mind while going for this procedure is that your ring, when you are preparing that ring, you have to use slightly larger diameter trephine burr so that a proper ring will be formed and it will be snugly fitting to the area where you want to go for vertical ridge augmentation. A study was done by Spin in the year 2014, and he stated that the results with the allogenic block were comparable to that with the results of the autogenous block. So that's why it is justified that you can go for use of allogenic bone rings for the vertical ridge augmentation when you are using vertical ring bone technique. Now, what regarding the future of this procedure? Whenever we are presenting any of the case, we try to always tell that how successful this procedure is. So I want to tell that very few studies have used this technique in the literature. We also have published a case report and a case study, that is case series, which has been published recently in a PubMed Index journal. But there is scarcity of the randomized control trials. Longitudinal studies are not yet done. All the reports which you will be finding on the internet or in the literature, they are all case reports or case series studies, and follow-up is also less. So when you say that any technique, whether it is successful or not, you should at least have some of the evidence of at least 5 to 10 years of follow-up. We also did around 20 cases. Out of those 20 cases, we got failure in 2 to 3 cases because there was higher resorption rate. The implants were exposed, implants were stable, but the ring was totally resorbed. So whenever we have to go for such techniques, first you should try this with a single tooth implant. Try to achieve the results with single tooth implants, and if you feel that it is fine, then only you should proceed with the multiple teeth. So similar thing, I also want to tell you. This was a very brief and short presentation, as organizers had told me that it should be 20 to 25 minutes. I hope it was not that boring. If you have any questions, you are free to ask me. If I'm able to answer that now, I will answer it. If not, I will try to find out the answers and then I will answer it to you. With this, I will like to thank the organizing committee for giving me this opportunity. I hope you have liked the presentation, or at least you understood what I was trying to tell. This was the innovation which we are trying in our clinic, in our college, to have something new for the implant practice. And finally, I want to thank you all for your patient learning.
Thank you, sir. Thank you for your wonderful presentation. I would like request the participants, if any queries, kindly drop your questions to the chat box so that our speaker can answer.
Ma'am, I have got 2 questions from Dr. Raghu.
Yes, sir. Yes.
Yeah, so he has asked me how the dimension of the ring to be placed in the patient is decided. So it is depending upon what diameter implant you are placing and what is the dimensions of the defect. So if defects are, say, 4 to 5 millimeter defect is there, then we are selecting a ring which is around 5 to 6 millimeter for snug fitting and for proper contact to the bone. Secondly, he has asked me, is this technique applicable to the posterior teeth augmentation and implants? Posterior teeth, they are load bearing areas. And if you are using giving a load onto those implants directly, it might create a problem. I have not come across any of the studies where it has been utilized for the posterior teeth. Whatever cases we have also done, they are basically done for the anterior teeth. So it is a very good question. We will try this technique in posterior teeth, and whatever results we are getting, we will be happy to share it with you. I hope, Dr. Raghu, you have got my answers.
Thank you, sir. Thank you for your wonderful presentation and your queries, answer the questions. Thank you, sir.
I think, ma'am, there is one more question. I will just check it. Okay.
Oh, yes.
Yes, just said thanks to me. Thank you, Dr. Raghu.
Thank you, sir. Thank you so much.
Thank you, ma'am. Thank you.
Now, I would like to invite our second speaker of the session, Dr. Rajat S. Bajaj, Certified Invisalign Orthodontist, Private Practitioner, Nagpur, India. Dr. Rajat is dedicated orthodontist with the knowledge of dental procedures, hygiene products, devices, and solutions with specific interest in preventive care. Technically savvy professional with strong surgical evaluation and treatment skills. Dr. Rajat did various presentations in national and international conferences and received various awards and grants. He is the Vice President of Medical Student Council, MUHS, Nasik, and also received Best Senate Member Award. He is currently attached to 8 plus dental hospitals and contributed in the field of dentistry for more than 15 years. Dr. Rajat's topic for today's webinar is non-surgical approach for correction of class 2 malocclusion. We would love to hear from you, sir. Over to you, sir.
Hello. Ma'am, is that audible?
Yes, sir, you are audible. You can start your presentation, sir.
Good afternoon. First of all, I would thank the organizers so that they are given me the chance to present in such a esteemed conference. Also, I would like to thank Dr. Dia so that she had invited me and she had given me a chance so that I could keep my views on the mandibular retrognathism, which has been recently found in many of the cases. Basically, if we consider, there are 3 types of occlusion, that is class 1, class 2, and class 3. So according to angle, the class 1 is where it is basically a normal relationship. Basically, the part of angle was what he kept into the mind is the permanent first molar. So the mesiobuccal cusp of the maxillary first molar is aligned directly over the mesiobuccal groove of the mandibular first molar. That is class 1. If we come to the class 2 malocclusion, in class 2, as we can see, the distobuccal cusp of the permanent maxillary first molar coincides with the mesiobuccal groove of the permanent mandibular first molar. In class 2, in class 3 relation, we can see that the dental arch is in the mesial relation to that of the maxillary dental arch. The class 3 relation is where the mesiobuccal cusp of the permanent maxillary molar is situated over the embrasure between the permanent mandibular first and second molar. So the topic for our today's discussion is the class 2 malocclusion, where we can see that the lower dental arch is in the distal relation to the upper dental arch. It has 2 divisions, class 2 division 1 and class 2 division 2. In class 2 division 1, what we can see is the class 2 molar relation, proclined upper incisors, V-shaped maxillary arch. We can notice the abnormal muscle activity, which shows the hypotonic upper lip, lip trap, hyperactive mentalis activity, and increased overjet. Similarly, in class 2 division 2, what we can see is the class 2 molar relation, lingually inclined, either upper centrals or both upper centrals or upper laterals. Mostly both the central and lateral, they are retroclined with the prominent canines. What we can see is the wide and squarish arches, and maximum in maximum class 2 division 2 cases, we can see that the deep overbite is there, which is traumatizing the lower incisors. So in class 2, the class 2 malocclusion, it is basically what we can see that it is observed. It is an observed clinical problem in many of the patients, because the class 2 malocclusion is recognized easily by the health professionals as well as by many of the patients. The correction of the class 2 may constitute nearly half of the treatment protocols. So in class 2 malocclusion, we can see the 2 categorization can be seen. First is, it is in the growing patients and non-growing patients, skeletal class 2 and dental class 2, and similarly in non-growing also it is divided into skeletal and dental. The class 2 can be mainly due to either maxillary prognathism or mandibular retrognathism, or both of, or combination of both. In maxillary prognathism, the growing patients, we can see that the headgear can be given for the orthopedic correction. In mandibular retrognathism, the myofunctional appliances can be given, which are our topic of concern for today. And in combination of both, that is maxillary prognathism and mandibular retrognathism, mainly headgear or myofunctional appliances can be given. But in case of dental class 2, the orthodontic treatment can be done The orthodontic treatment, mainly it constitutes either by using the fixed functional appliances along with the fixed orthodontic treatment or with the help of the molar distalization. In mild to moderate cases, orthodontic camouflage can be done by either upper 4-4 extraction, lower 4-4 extraction, and in skeletal cases, the ortho followed by the surgical and followed by post-surgical ortho can be done. So mainly we are now coming to the introductory part of the functional appliances. Mainly these the functional appliances. Mainly the functional appliances are referred to as the appliances which either transmit, eliminate, or guide the natural forces or the musculature. The appliances are mainly used for the growth modifications. Mainly they are aimed at intercepting and treating the jaw discrepancy. They can bring about the following changes. An increase or decrease in the jaw size can be brought about. A change in the spatial relationship of the jaws can be seen. The change in the direction of the jaws can be seen. Similarly, acceleration in the desirable growth of the jaws can be seen. Now, if we come to a classification of the appliances, the classification of the functional appliances are like tooth-borne passive appliances, tooth-borne active appliances, tissue-borne passive appliances, removable and fixed appliance, and group 1, group 2, and group 3 appliance. Like tooth-borne passive appliance, these appliances are mainly that they have got no intrinsic force to be generating. They are mainly dependent on the soft tissues and the muscular activity to produce the desired treatment results, like activator and bionator. Like in tooth-borne active appliance, they include the modifications in the activator, like introducing the expansion screws into an activator or any springs which provide the intrinsic force for the transverse or the anteroposterior changes. Then coming to the tissue-borne passive appliances, the tissue-borne appliances are mostly located in the vestibule and have little or no contact with the dentition, like we can see in the Frankel appliances. Then removable and the fixed appliances, as the name suggests, the removable appliances can be easily removed and reinserted by the patients, and the fixed appliances, they cannot be removed at the patient's will. Then group 1, group 2, and group 3. So group 1, they mainly consist that the appliances which transfers directly forces onto the teeth, like oral screen or inclined plane. Like group 2 is the repositioning of the mandible, and the resultant is the force transmitted to the teeth and the other structures, like activator and bionator. And group 3 is the appliances that can reposition the mandible, but their area of operation is mainly vestibule. So Frankel regulator can be seen in that. Like treatment principles, which we can see, the functional appliances mainly work on 2 treatment principles, the force application and force elimination. If we see towards the advantage of the functional appliances, the advantages are it enables the elimination of the abnormal function. The treatment can be started at an early age. It gives wonderful results. As the treatment starts, nearly the early psychological disturbances can be avoided. The appliances are fabricated in the lab, thus it takes less of the chairside time. They do not interfere with the oral hygiene. Mostly these functional appliances can be worn at night, as it gives the wonderful results if worn at night during the sleep. Now coming to the disadvantages, as such disadvantages are not there, but just there are a bit limitations to the appliances. They cannot be used in the adult patients in whom the growth has already been ceased. They cannot bring about. They cannot be used to bring about the individual tooth movement. The patient cooperation is necessary. It may require the pre-functional orthodontic tooth movements, and the fixed therapy may be required at the termination of the treatment for the final treatment detailing of the occlusion. Now, if we see what are the objectives of the functional appliances, the objective is it eliminates the functional and the occlusal factors. It establishes the new functional behavioral pattern. The harmonious development of the dentofacial structures. It unlocks the malocclusion and stimulates the growth by applying the favorable forces. Now, if we come to the inventions of the appliance, so various inventions has been carried out with this functional appliances. Like monoblock was given in 1902 by Robin. followed by the Anderson activator in 1908. Then 1960s, the Balter's bionator has been given. Finally, 1964, the Bilmer skeletonized activator, and many of the modifications of the activator has been given. And in 1977, the William Clark's twin block has been given. This appliance is widely used. Now, mainly we can see the role of the growth. Mainly we can see the various hypotheses has been given for these appliances. What we can see that the growth of role of hormones, role of facial muscles, like role of hormones. If we see, mainly the somatomedin is responsible. Mainly the somatomedin is responsible for the growth of the mandible. If we see the facial muscles, various studies by Woodorish and Wood has been given, which says that the lateral pterygoid is responsible for the growth of the appliances. The role of the facial growth spurt is important, as during the pre-adolescent period, the growth spurt, during the growth spurt, these appliances works wonderful. The role of glenoid fossa, if we can see, if we see the glenoid fossa remodeling and posterior superior positioning of the condyle is important for the working of the appliance. Various theories has been given for the stage-wise proclination of the mandible, or one-step proclination. Now, if we see the mode of action of the appliances, that if as soon as the functional appliance is given, it increases the contractile activity of the lateral pterygoid muscle, which intensifies the retrodiscal pad. The repetitive activity of the appliance, it helps in the increase in the growth stimulating factors, which gives rise to the enhancement of the local mediators. The local mediators, as the condyle is a secondary cartilage, it leads to the development of the secondary condyle cartilage, which leads to the addition of the subperiosteal ossification at the posterior border of the mandible, which leads to the supplementary lengthening of the mandible. And in this way, we can see that the mandible is proclined. Now, we can see the effects of the functional appliances. It helps in the acceleration of the mandibular growth, restriction of the maxillary growth, which is called as the headgear effect. It also helps in the backward tipping of the maxillary incisors and forward tipping of the mandibular incisors and the entire mandibular dentition. And differential eruptions of the teeth can be done by the selective trimming of the appliances. Now, if we see the action of the functional appliances, the changes which we can see are the orthopedic changes, the dentoalveolar changes, and the muscular changes. In orthopedic changes, we can see that these are capable of accelerating the condylar growth. They are designed to have a restrictive influence on the growth of the jaws. They can change the direction of the growth, and they can bring about the remodeling of the glenoid fossa. Then dentoalveolar changes, as I had mentioned it earlier also, they can bring about the changes in the sagittal direction, transverse direction, and the vertical direction. Mostly, the functional appliances allows the upper incisors to tip palatally and lower incisors to tip labially. And as we can see that the muscular changes which we can see, they are like that they improve the tonicity of the orofacial musculature. Now, the case selection, if we come to a case selection, traditional way, if we can see the case selection in the functional appliances, the main is class 2 division 1 with the uncrowded lower arch, and this is the view. And in this view, nowadays it is not, it is discarded. Now, the main factors are age group, the pre-adolescent age group, or the age group in which there is a growth spurt. Then the dental considerations, we can see that the arch which is devoid of the irregularities like crowding and rotations. the skeletal skeletally, what we need to see in the patients is that the skeletal should be in skeletally moderate to severe class 2 division 1 cases with the retruded mandible. They are the most suitable cases for functional appliances. The high angle cases are also good, but in high angle cases, we need to increase the vertical bite of the patient while taking the construction bite. Basically, low angle cases, they respond very well. Where it is average to horizontal growth, they respond very well to the functional appliance therapy. Then VTO, it is a visual treatment objective. Basically, it is a diagnostic test. In photograph, which we can see, it is a diagnostic test which is undertaken before making a decision to use the functional appliance or not. It enables us to visualize how the patient profile would be after giving the functional appliances. Also, it is asked by patient to perform, like we had asked the patient to bring the mandible forward so that the profile is considered as a positive VTO. Then if we can mainly the sagittal correction, if we see, the correction occurs by 6 to 7 mm, in which we can see the condylar, the changes occurring with the forward positioning according to the various studies. The condylar growth is 1 to 3 mm. The fossa growth adaptation is 0.5 to 1 mm, eliminating the functional retrusion 0.5 to 1.5 mm. The favorable growth direction like 0.5 to 1 mm, withholding of the maxillary growth. In patients with the excessive maxillary growth, it is 1 to 2 mm of the restriction can be seen with the maxilla. The differential eruption is between 1.5 to 2.5 mm. In many cases, 3 mm can be seen. And the headgear effect, that is the restrictive maxillary growth, is 1 to 2 mm. Then moving on to the fixed functional appliances. The fixed functional appliances are the appliances in which they are basically fixed appliances which can be given with the which can be basically given with an orthodontic appliances like orthodontic fixed appliances, braces and all. Basically, it is used primarily in the actively growing patient with the favorable facial growth patterns, the class 2 skeletal pattern with mandibular deficiency, the lack of vertical development in the lower facial height, the mandibular incisors teeth should be positioned upright over the basal bone, and the maxillary and the mandibular teeth should be well aligned. Now, contraindications for giving these functional appliances or fixed functional appliances. The shallow overbite, non-growing individual, if the patient is having class 1 molar relationship, proclined mandibular anterior teeth, increased lower facial height, class 2 skeletal pattern with maxillary excess, decreased overjet, retroclined maxillary anterior teeth, and the patient with more of the gummy smile. Now, leveling and anchorage preparation, if we see, basically after starting with the fixed orthodontic treatment, alignment of the maxillary and the mandibular anterior teeth during the initial phases, leveling and aligning, it should be done. The anchorage preparation should be done. Mostly the TPA, transparietal arch, is added to avoid the extrusion of the upper molars. The full size arch wire should be inserted into the bracket in both the arches before the placement of the fixed functional appliances. Arch wire should be tied or cinched back posteriorly, which also increases to the anchorage. Also, in vertical cases, the lower second molars are to be included, not the upper, because if they extrude, it will lead to the open bite. In addition, the clinician can place the posterior tip back bends with the mandibular arch wire to enhance the anchorage. While placing the fixed functional appliance, 5 degrees of the lingual crown torque, or what you can say, the labial root torque can be given. Now, here are some articles which we can see. The mechanical effects of the fixed functional appliances on the craniofacial structure. This article was given in Angle Orthodontics in 2009, which shows that the pterygoid plate, the fixed functional therapy causes a posterior superior displacement of the pterygoid plate and the mandibular dentition, and thus it can lead to the correction of the class 2 malocclusion. Now the treatment effects, if we see the skeletally, we can see the condylar remodeling, glenoid fossa remodeling, and the condylar position changes within the fossa. The dentally, we can see as herbs appliance is one of the fixed functional appliances. Nowadays, we use the forces which has been given by the American orthodontics. The telescopic mechanism, basically, which we can see in the forces appliances. It produces a posterior direction of the force in the upper teeth and the anterior direction of the force in the lower teeth, which is resulting in the distal tooth movement in the maxillary buccal segment and the mesial tooth movement in the mandibular segment. The mandibular teeth are moved anteriorly, maxillary teeth are moved distally. Mesial movements of the lower molars can be seen. The arch perimeter increases during the treatment, and the arch width expand laterally in both the canine and molar regions. Now, here are some other articles. In Journal of Orthodontics and Dentofacial Orthopedics in 2013, that shown that the class 2 malocclusion, in class 2 malocclusion, mainly the primary part is the dentoalveolar segment. They act similar to the fixed functional appliances in long term by placing the short class 2 elastics. Similarly, the class 2 corrections in the patient treated with the fixed functional appliances, where they have given the this was a comparative study in 2000 in AJODO, where the larger group was given the herbs appliances, and the favorable and unfavorable vertical changes were more pronounced with this group. In temporomandibular joint also, the fixed functional appliances in TMJ changes can be seen, where the posterior joint spaces had changed and the condyle was more posteriorly positioned in the glenoid fossa. We can see some cases. In this case, we can see these are the pre-treatment extraoral photographs of the patient, where we can see the lips are incompetent. The frontal photograph shows the lips are incompetent. We can see the prognathic maxilla. The teeth are proclined, upper incisors are proclined. In the lateral view, we can see the mandible is retrognathic. These are the intraoral photographs. The intraoral photograph shows the class 2 relation, or more of end-on relation, more towards class 2. There is slight deviation in the upper and the lower arches. Spacing can be seen. Normal orthodontic treatment was carried out in the patient with the fixed functional appliance. These are the photographs of the forceps appliance given. While placing the forceps appliance, nowadays we are placing the helix distal to canine, as direct placing of this arm in the forceps appliance can lead to the breakage of the canine brackets. You can appreciate the changes in the patient. This is the second case where we can see class 2 division 2 in the patient. Retrognathic upper teeth can be seen. The patient is in the mostly the patient is of 21 years. Already he has finished the growth stages. These are the intraoral photographs where the retroclined upper central incisors can be seen. The mini implant is given in this case, as we can appreciate the TADS. TADS appliance is given for increase the anchorage value. These are the post-treatment photographs. Similarly, in this case, patient is having a short upper lip. Incompetent lips can be seen. These are the intraoral photographs where patient is in the class 2 relation. crowding can be seen with the lower arch. With the use of forces appliance, the forward thrust to the mandible has been given, which has converted the patient into class 1. See the extraoral changes. You can see the competent smile of the patient. This is the case of class 2 division 2 of the patient, where directly forces or directly pre-ortho, like ortho cannot be done. So in this case, what we had done, the canine were also in the erupting stage. What we had done in this case, the implants was placed, micro implant were placed in between the incisors. Initially, the intrusion was carried out. Intrusion with the incisors was carried out, followed by the fixed orthodontic treatment, and then the forces was given to the patient. And these are the treatment changes. Thank you. I would like to thank all the participants for a patient hearing. And thank you APADENTO Academy for giving me a chance to share my views on the non-surgical approach for the correction of mandibular retrognathism.
Thank you, sir. Thank you, sir. Thank you for your wonderful presentation. And I would like to request our participants to drop your questions and queries in the chat box so that our speaker can answer.
Ma'am, I've got one question from Dr. Raghu sir.
Yes, sir.
Sir, Invisalign mandibular protraction appliance has not been given yet. But basically, Invisalign has come with an Invisalign teen part, in which they are claiming that they are giving in the comprehensive treatment package, they are giving with the Invisalign mandibular protraction appliance.
Thank you, sir. Thank you for your wonderful presentation and the question session. Thank you so much. And I would like to welcome our third speaker of the session, Dr. Pritiva Prasad, Professor, Department of Oral and Maxillofacial Pathology, Ajman University, UAE. Dr. Prathibha Prasad has worked as a dentist, researcher, and an educator for 20 years with over a decade of experience in teaching and administering a wide range of academic curricula in UAE. Dr. Prathibha is experienced in program writing, editing, and accreditation with national and international bodies. She has experience in general dentistry, rotary endodontics, and veneers. She was active participant in the molecular research with renowned scientists and spearheaded molecular research and also working on the lung cancer caused by the water pipe smoking. Also received various grants from contributed to the editorial and review board member for prestigious journals. Dr. Prathibha contributed with 20 plus publications along with various presentations in international and national conferences. She has an impeccable track record of an excellent work ethic, unparalleled attention to detail, and knack for executing high performance under pressure. Dr. Pratibha's topic for today's webinar is Preventive and Advanced Treatment Strategies on Pre-Malignant Disorders. Over to you, ma'am. We would love to hear from you.
So today we are going to discuss about potentially malignant disorders. So what do you mean by that? As a practitioner, you're going to look at many lesions, and they're broadly classified as white lesions and red lesions, which have a very high risk of malignant transformation. And they come under two categories, lesions and conditions, and that's what we're going to study today. We'll start with defining them, and then we'll describe the etiology and clinical features of leukoplakia, that's a premalignant lesion, and we'll discuss what is dysplasia, which is the histopathological diagnosis of these lesions and conditions. And we'll also define and describe what was earlier called as carcinoma in situ, which is now referred to as intraepithelial carcinoma. Premalignancy can be differentiated from malignancy only by the malignant tumor's ability to invade and to metastasize. And the best predictor of this potential malignant transformation is the degree of dysplasia which we see histologically. So whenever there is a red and white patch, biopsy is mandatory. And dysplasia means bad growth or abnormal growth. And this term is given for the cytological abnormalities and the architectural changes which we see in both malignant and premalignant cells. The definition of precancerous lesion is that it is a benign morphologically altered tissue that has a greater than normal risk of malignant transformation, and the examples would be leukoplakia, erythroplakia, and palatal lesions which are seen in reverse smokers. An oral precancerous condition is defined as a generalized pathological state of the oral mucosa associated with a significantly increased risk of cancer. And the example would be oral submucous fibrosis, which we're going to discuss. And the other examples are lichen planus, discoid lupus erythematosus, and actinic keratosis. Leukoplakia was defined by WHO as a white patch or a plaque that cannot be characterized either clinically or pathologically as any other disease. These are the other premalignant lesions which come under that category of tissues which have a higher risk of malignant transformation. Leuko means white and plakia is for plaque. What is the reason for its white appearance? We'll discuss in detail later, but here I would like to tell you that the clinical color is because of the thickened surface keratin layer, and this appears white when it is wet, of course, because of the surrounding saliva. Also because of the thickened spinous layer, which masks the vascularity of the underlying connective tissue. Hence, the tissue appears even more white. Leukoplakia is one of the most common oral precancer, comprising about 85% of the lesions, which has the potential to convert to malignancy. The specific etiology is unknown. I'll discuss with you the list of etiology which have been hypothesized. Discussed are genetic, tobacco with alcohol, which together form a synergistic effect, ultraviolet radiations, even microorganisms like Treponema pallidum and Candida have a role in the occurrence of leukoplakia because they've been seen or identified in association with leukoplakia, and trauma as well, which we could understand on the basis that any chronic irritation could lead to such transformation. It is usually seen in older individuals, and female have higher risk of malignant transformation compared to males. And the sites which are at a higher risk of malignant transformation are posterolateral tongue and floor of the mouth. And these are the same sites which are very common in squamous cell carcinoma. So that is a clear indication that there is a process of transformation, usually from normal to premalignant to malignant. So based on the appearance, it is classified clinically into different types. It could occur as a very thin leukoplakia in the early stages. It could occur as a homogeneous, thick leukoplaque-like lesion, that is white plaque-like lesions. If there are any granular structures within this white plaque-like structure, it's called as granular leukoplakia. If it's an exophytic growth, it's called as versiform leukoplakia. And there is a specific type called as proliferative verrucous leukoplakia, which is caused by Epstein-Barr virus. Verrucous basically means that they're keratotic plaques with rough surface projections, and these have high risk of malignant transformation. This is a nice image to show you a normal mucosa, a thin leukoplakia, a thick fissured leukoplakia, granular, you can see the granules in between, that's the granular, and versiform. The exophytic projections are the versiform leukoplakia. And there is a type where there is a mixture of red and white lesion that is called as speckle leukoplakia. So the clinical lesions can represent a huge spectrum of diagnostic features, which could range from inflammatory reaction to benign or malignant changes. So how would you decide what's the appropriate treatment? In no matter what cases, if you see a suspicious white or red lesion, I told you that biopsy is mandatory. So you take a biopsy, whether it's incisional or excisional, you evaluate histopathologically, and then you decide your treatment options. So hyperparakeratosis, that is excessive keratin production, and the keratin type here is parakeratin with remnants of pycnotic nuclei. Acanthosis, that is increase in the thickness of the spinous cell layer, are features which are seen in normal appearing epithelium as well, and in premalignant lesions and conditions. These must not be confused as dysplasia. So let's see what is dysplasia. So the diagnosis histologically is dysplasia, and dysplasia has individual cell alterations and architectural alterations. So when it comes to the architectural alteration, there could be formation of bulbous retipex. As you know, the retipex are more like a test tube shaped or finger shaped. But if they become like a bulb, they're bulbous, then it is one of the architectural alterations of dysplasia. Basilar hyperplasia. Usually the basal cell of the epithelium has the capacity to multiply and proliferate. But when they are too many in number, the basilar layer itself, so that is called as basilar hyperplasia. So this is like a preparation to proliferate extensively and become carcinogenic. Hypercellularity, in general, you will see more cells in the epithelium than the normal, and they look crowded. And there is an altered maturation pattern of the keratinocytes. What it means is that the mitotic figures, which are usually seen in the basal and the parabasal layers, are also seen in the superficial layers of the epithelium, which is normally not seen. Okay, so that is the architectural alteration which is seen in the epithelium. What about the cytological alterations? You know what is a nucleoli. So the nucleoli becomes very prominent. The nuclei becomes hyperchromatic. I've explained to you what is hyperchromasia. So the color of the nuclei is enhanced, okay, and it is enlarged as well. So it is very prominently seen. So that's the hyperchromatic nuclei. And the nuclei is not that typical oval shaped. It will have different shapes. So that is called as pleomorphism, meaning multiple morphology, okay, several morphology. Normal nuclei to cytoplasm ratio is 1:4, but here it increases because I told the nuclei is hyperchromatic and enlarged. So nuclei occupies bigger space. So 1:4, 1 is nuclei and the 4 is the cytoplasm, but here the nuclei ratio will be increased, okay. What is mitosis? Nothing but the cell division which we see in the eukaryotes, and it is increased because there is a lot of proliferation and division which is happening. And it is not just the normal mitosis, even there is abnormal mitosis. So abnormal mitotic figures can be seen within the and poikilokaryosis is nothing but the multinucleation of cells, meaning there is more than one nuclei present within the cell. So all these are alterations at the cellular level. This is at the epithelial level. Okay, I'll show you some pictures to make you understand better. So this is the prominent nucleoli. So this is the nuclei. Nucleoli is present within the nuclei, and you can see how it's become prominent. Hyperchromasia is when the nuclei becomes dark in color. Okay, normally it is this bluish, but here it is like dark blue. Nuclear pleomorphism, you can see it is not oval in shape, it's like weird shape. Altered nuclear cytoplasmic ratio, the nuclei is so big that it is filling up the entire cell, and the cytoplasm has become lesser compared to the other cells, which if you notice here. And increased number of mitosis and different stage of mitosis also you will see. And abnormal mitosis is as well seen, and multinucleation, that is more than one nuclei within the cell. So if you just see these images, whatever I explained till now will be easily understood. I don't think you'll have any doubts. So let's see the histopathologically what are the things which we see. Acanthosis, an increase in the thickness of the spinous cell layer, and hyperorthokeratosis, there is no remnants of the nuclei in the keratin which is deposited. Again, acanthosis, that is number 2, increase in thickness of the spinous cell layer. And this is the inflammatory cells. It is called as juxtaepithelial inflammatory cell infiltration because it is just immediately below the epithelium. Juxtaepithelium means right next to the epithelium. And you can see the redder ridges are very broad. Okay, so these are the broad-shaped redder ridges, and we'll see basal cell hyperplasia. It's not very clear in this image, but basically you will see more than one layer of basal cells, the tall columnar cells. Okay. So these are some of the images for you to understand the architectural changes. The bulbous redder ridge, which you can see, and here you can see that there are more than one number of the basal cell layer, and this is not a sign of the normal maturity. Okay, and you will see mitosis even in the superficial layers. That's another sign of the architectural change. And whenever we are looking at dysplasia, we grade it based upon the extent of involvement of the epithelium in these changes. So both the architectural and the cellular changes, to what extent of the epithelium is it seen? So based on that, we classify it into mild, moderate, and severe. So in the mild dysplasia, okay, so this is for your understanding, and this is the histopathological picture. So you can see that all the changes are within the basal and parabasal layer. This is limited to the lower 1/3 of the epithelium. Moderate dysplasia extending up till the middle 1/3, that is the moderate dysplasia. You can see all the changes extending till the middle layer. And severe is extending beyond the 2/3 of the epithelium. Okay, so you can see that all the changes, the cytological alterations, are beyond the 2/3 the thickness of the epithelium. Okay, so that is severe dysplasia. So here you can see very clear distinction of all the three histopathological pictures. So this is a normal epithelium where there is just increase in the spinous cell layer, whereas in mild dysplasia there are cytological alterations which are seen in the lower 1/3 of the epithelium. If it is seen up to middle 1/3, it is called as moderate dysplasia. And if it is seen beyond 2/3, it is called as severe dysplasia. There's another grading of dysplasia where it involves the entire thickness of the epithelium from top to bottom, but it is not crossing the basement membrane and going into the connective tissue. That's when it's called as malignant. It is contained within the epithelium, but it is traversing through the entire thickness of epithelium, and that, they say, has to be treated like a carcinoma and is called as intraepithelial carcinoma. Although it is not broken the basement barrier, but it is still considered as a carcinoma because it is extending throughout the entire thickness. Okay. So I told you there are roles of certain microorganisms within leukoplakia. So I will just tell you about the Candida. So the leukoplakia caused by Candida is called as Candida Leukoplakia. Okay. So there are two ways it can act. The person is smoking, his immunity is down, so there is candidal infection. Person is wearing the denture and there is some irritation or friction causing keratosis, and that is followed by a candidal infection. And that results in leukoplakia, but the base cause is the candida. Okay, and the Candida Leukoplakia is nodular in appearance. Okay, so that's why the candida is seen in association with a lot of leukoplakic cases and is thought to have a very important role in the incidence of leukoplakia. So I told you two such instances. One is when there is immune deficiency, and the other when the person is wearing denture. Two scenarios. So how do you manage it is either by surgical excision, you remove the whole lesion, and electrocautery can be done. You can use an electric current and burn it. That's what is called as cautery. So in this, we'll study about erythroplakia and about oral submucous fibrosis. So erythroplakia is the other pre-malignant lesion, and oral submucous fibrosis is a pre-malignant condition. Erythro means red, plakia means plaque. So the term erythroplakia itself is telling you that the lesion is red and velvety in color, and it is a plaque-like lesion seen in older men. Okay, so here you can see, so this reddish area which you see is the erythroplakia, and if it is mixed with the white lesion, that is called as the speckled leukoplakia or speckled lesion, mixed lesion. Why it is red in color is because there is no keratin production. Okay, that's the difference between the leuko and erythro. In leukoplakia, there is a lot of keratin deposition. That's what is giving it a white appearance. Whereas in erythroplakia, there is no keratin production. So I told you that epithelium or the mucosa tries to protect itself by forming keratin because it wants to ward off all the toxins entering. But when the epithelium itself loses its inherent nature, then it cannot produce keratin anymore. Okay, so the dysplastic changes are so much, and the epithelium has actually become atrophic. Atrophy means decrease in the thickness of the epithelium. Okay, so because it is atrophic and dysplastic, and there is no keratin production, so the lesion appears reddish. There is no keratin absolutely, because the epithelium has lost its inherent ability to produce the keratin. Epithelium nature is to produce keratin and to protect itself. Okay, but in this scenario, it has lost its ability to form any kind of keratin, and the epithelium has become very thin or atrophic along with dysplasia. Okay, so that's why erythroplakia will have a higher risk of malignant transformation, and also there is no keratin to protect it anymore. So erythroplakia has a higher risk of malignant transformation, and this there are a lot of chronic inflammatory cells also seen. So the treatment, of course, you excise it, either incisional or excisional biopsy, take it for further examination if it is very big. But if you've already removed it, then you're good to go. And the floor of the mouth and the lateral tongue, I showed you, even in the leukoplakia, these are the two sites which have a very high risk of malignant transformation. That's why it has to be checked very thoroughly under the microscope to see if it has already become malignant. Okay. So let's continue with the oral submucous fibrosis. That's the pre-malignant condition. So it is defined as an insidious chronic disease affecting any part of the oral cavity and even the oropharynx, okay, not the pharynx, entire pharynx, but the oropharynx, and is always associated with juxtaepithelial inflammatory reaction. Juxtaepithelial means just below, okay? You will see a band of inflammatory cells just below the epithelium. This is followed by fibroelastic changes in the lamina propria, that's your connective tissue, with epithelial atrophy. So two things we see together: epithelial atrophy, fibroelastic changes in the connective tissue. Okay, these are the two things. This leads to the stiffness of the oral mucosa, causing trismus and difficulty in eating. The normal opening of the mouth will be reduced or restricted, and that is called as trismus. Okay, let's see what is the etiopathogenesis. So there is something called as aracanut. Again, these people chew it. Okay, it's something which they chew, and again, it is seen in various parts of the world where people chew aracanut along with other condiments, and this releases alkaloids. And that's what stimulates the fibroblasts which are present within the connective tissue to form increased collagen. You know, fibroblasts are the cells which forms collagen. So they're stimulated by some products which are released from the aracanut. And there's something called as tannin, which is again released from the aracanut, that causes a stabilization, or how can I put it, as whatever excess collagen is produced, it is not destroyed. Your body recognizes it as extra collagen, but it's not doing anything about it. So that's what tannin does. It protects the extra collagen which is deposited. Plus, these collagen become resistant to degradation. Even if there is a lytic activity, it doesn't break down at all. So that's the quality of the collagen which is being produced in this condition. So that's what results in excessive deposition of collagen, and that's what causes the stiffness of the oral mucosa. Oral, you know, oral cavity. Submucous is the submucosa. Fibrosis is excessive fibrous production or deposition. This is resulting from the increased production of collagen by the fibroblasts. How are the fibroblasts stimulated? It is by the aracanut, the alkaloids which are present in the aracanut, and the tannin which is present in the aracanut. Okay, so tannin has a role in the decreased breakdown of the fibers which are deposited. So both these together, that is increased production of collagen and decreased breakdown of collagen. Okay, let me repeat it again. Increased production of collagen plus decreased breakdown of the collagen together causes excessive fibrosis in the oral cavity. Okay, so that's the oral submucous fibrosis. I've already told there is increased collagen production, decreased collagen breakdown, and along with that, all the collagen produced is stabilized. It is in a stable condition. So it's the tannin I told you in the flow chart. That's what helps to stabilize the collagen. How does it stabilize is what we're going to look at. It does what is called as cross-linking. Okay, so when it cross-links all the collagen that is produced by the fibroblast. That's what makes it resistant to degradation. So tannin has a very important role in oral submucous fibrosis. Along with tannin, the betel nut also has copper. Even this copper helps in cross-linking of the collagen fibers which are deposited. Okay, so it's a constituent of the enzyme lysyl oxidase, and that's what helps in the cross-linking. So both of these together, the copper and tannin, causes the cross-linking. What's the result of cross-linking? Whatever collagen is produced becomes resistant to degradation. Okay, so just a quick summary. So aracanut has alkaloids which are released that stimulates the fibroblast to form high collagen. Okay, more collagen is produced. There is tannin in the aracanut and copper in the aracanut. So both of them make whatever collagen is produced stabilized by cross-linking it, and that makes them resistant to any phagocytosis or lysis, if I can say. So both these together, that is increased collagen synthesis and decreased degradation of collagen, results in excessive accumulation causing OSMF. Okay, so clinically, I already told you that it will have fibrosis. So that's what is reflected even in clinical when you're seeing it. And when you palpate it, you can see very thick fiber deposition. Young females and buccal mucosa is the most common site, as you can see here. And the mucosa, this is a man. But I was referring to the buccal mucosa site. The mucosa becomes blotchy, marble-like, and very stiff, okay? Very hard when they say marble-like, and even in appearance, very whitish it will be. And the tongue, if it is involved, will become immobile. You cannot move your tongue. That's what happens if tongue is involved in OSMF. And trismus, that's the inability to open the mouth, is seen. And in severe cases, you can see that it is so restricted that the patient interincisal distance, this looks lesser than 20 millimeters. This is the only amount of mouth opening the patient can do, and this is seen in the severe cases. Along with that, in the beginning especially, there is a burning sensation whenever the patient is eating any spicy food, any hot food. There is a burning sensation within the oral cavity, whether it's buccal mucosa, tongue, or whatever is affected. All this will have burning sensation, and some amount of pain also is associated. So there are two stages. There are two ways of staging OSMF, like how we graded leukoplakia as mild, moderate, severe. So same way, there is functional grading and clinical grading. Okay. So the functional grading depends upon the amount of the mouth opening, which we discussed just now. So 20 millimeter is type A, 11 to 19 is type B, and 10 is the severe, that is the 10, that is the C. And clinically, if only the fascial bands are seen, that's type 1 or the clinical stage 1. And 2 is when both fascial and buccal bands are affected. When all the three, that's the fascial, buccal, and labial are affected, that's the stage 3 we can see. So the normal mouth opening in any patient, they say, is 3 finger or 2 finger based on your size, your own hand, the patient's own hand. That's the normal mouth opening. You can all check by your fingers, the 3 fingers, okay? And you can see here that in these 2 patients, it is almost 2 finger opening. So this you can say is somewhere in between. And this is the most severe case, that is about just 10 millimeter of mouth opening in this patient. And you might be shocked to see that there are small kids who are indulging in this habit, and they're all affected by OSMF. So histopathologically, what do we see is hypertrophic epithelium in the beginning. In the earlier stages, the epithelium reacts by forming an increased thickness. There is hypertrophy of the epithelium, and there's a lot of inflammatory cells which we see. But this is in the beginning stage of the oral submucous fibrosis. But as the lesion progresses, you can see that the rete-ridges are all flattened, and the juxta-epithelial inflammatory cells are still seen, that is just below the epithelium. And there is an abundant deposition of collagen fibers. You can see there is collagen everywhere. All this is collagen. So that's what is responsible for the fibrosis, as we discussed. And again, the lesion will progress further, and the epithelium will become completely atrophic, okay, like we saw the atrophic epithelium in erythroplakia. Atrophy means decrease in the thickness of the epithelium. You can see it's so thin. Epithelium has become very thin, whereas if you see the connective tissue, it's entirely fibrosed. Extensive fibrosis, thick collagen bundles are deposited all over the submucosa, and along with that, the muscles are coming in contact very close to the lesion because of the fibrosis and the thinning of the epithelium. The muscular layer is coming very close and superficial, and this is another reason for the trismus which we see in this patient. So in the beginning stages, the epithelium reacts by hypertrophy. What is hypertrophy? Increase in the thickness of the epithelium. So atrophy is the thinning of the epithelium or reduced thickness of epithelium. So in the beginning stage, it is hypertrophy. Later stage, we see atrophy. And in between, we see inflammatory infiltrate, okay, flattening of the rete-ridges, and you can see that there is excessive deposition of the collagen fibers. All this is in between. And as the lesion has progressed to a very severe stage, you see atrophy, dense collagen fiber bundle, and muscular layer is also undergoing degeneration and has come very close to the submucosal layer. Okay, so that's what causes together the fibrosis, the stiffness, the trismus is all a result of all of them together. So there are several ways of managing this. So there are some people who take a very rich vitamin diet along with the iron. Okay, so this has worked with some people, especially when it comes to relieving the trismus, okay, but it doesn't have like a proper it's not actually a proper treatment. You can say this is like a supportive treatment which we do. So you can prescribe a very high vitamin rich diet, and also you can ask the patient not to eat the spicy food, because some patients the spicy and hot food are also an etiologic agent. So you ask them to avoid those foods. And B complex along with the iodine. So you can use it either orally, like normally we take the vitamin B complex, or you can use it as an injection as well. And this is seen to help a lot with the overall condition of the patient, especially the B complex. And steroids, the hydrocortisone injection, along with the hydrochloride, can be injected locally, okay? With wherever there is fibrosis, you give an injection every 2 weeks. Fortnight means every 2 weeks. So you give an injection of this, and over a period of time, there is an improvement which is seen. And Placentrix is nothing but a placental extract. How it works is because of its regenerative capacity. So it kind of heals that area and regenerates the epithelium and the mucosa back to its original condition. And even hyaluronidase can be given, because hyaluronidase will break down all the excessive collagen which is formed, because that's what is causing the fibrosis in the patient. So you want something externally to break it down because the patient's body is not doing it by itself. So you inject hyaluronidase so that it can break down and make like a normal connective tissue. And in those patients who have trismus, that is difficulty in opening the mouth, especially the severe patients in which it's limited to just 10 millimeter, okay? So for those, you do oral physiotherapy. You must have heard physiotherapy for fractures and other things, yeah? So oral physiotherapy is also something which is existing, and you should be aware of it. So oral exercises are advised, and especially in the early and moderate cases. And this includes the mouth opening and ballooning of the mouth gradually. You can also do a forceful mouth opening by using a screw. So you put a screw, okay? You use a metallic, like a caliper kind of a thing, and then you open it slowly, okay? So these are called as acrylic surgical screw, not the metallic, sorry, acrylic. So this slowly opens the mouth to increased millimeters. Suppose it was 10, then after say 1 or 2 weeks, it goes another 2 millimeters up, another 2 millimeters. So slowly you're training the mouth to open more and more, okay? Thank you for listening.
Thank you, ma'am. Thank you for your wonderful presentation. And I would like to discuss about the guidelines to download your certificate for the participants. The link will be provided in the chat box so that kindly you can check the chat box and work accordingly. And I would like to uh, present you the guidelines. First of all, I would like to thank everyone for attending this today's session, a webinar on preventive and advanced treatment strategies in dentistry. And steps to download the certificate. First, click on the link provided, and you can find the sign in option in that APADENTO account. If you are a new member, then sign up, creating an alphanumeric password, and you will be getting an OTP to your mail using that, and you can kindly sign into your account. After logging in, you can find the menu on the left side. Click on the certificate and rewards. You can find the webinar name, like a webinar on preventive and advanced treatment strategies in dentistry. Then click on the download certificate. You will be getting the certificate online. And you can find the link for the new member registration and existing member registration in the chat box. Thank you for attending our webinar, and have a nice day. Thank you. Thank you all. And once again, I would like to tell you that download certificate link is provided in the chat box. Kindly take a look at it. And any queries regarding the certificate downloads and any inquiries about it, you can contact us through WhatsApp with the provided number in the website. Thank you. And that's all for the today's session. A very thank you and have a nice day.